I want you to try and visualize a jigsaw puzzle. But forget the kind you dump out of a box on a rainy Sunday. I want you to imagine a puzzle made of living tissue.
Okay.
The pieces are soft, they bleed, and here's the kicker. Each piece has to carry its own life support, its own plumbing, wherever you move it.
That is a very vivid and, honestly, a slightly high-stakes way to open a discussion on surgery.
But it's true, right?
Oh, you're not wrong. Unlike a cardboard puzzle, if you force a piece that doesn't fit in reconstructive surgery, well, the piece dies, and the patient is left with a necrotic hole in their face.
Which is the terrifying but absolutely fascinating reality we are diving into today. We've got a stack of clinical notes, surgical diagrams, all centering on one specific patient.
Right.
But really, this isn't just about him. It's about the incredible engineering required to rebuild a human face.
It's totally architectural. I think the public tends to think the surgery part is just, removing the bad stuff.
Yeah,
Tumor.
the cutting out.
But as these sources show, removing the tumor is really just the demolition phase. The real magic, the artistry, is the construction project that comes after. How do you rebuild a nose so that form and function are, well, indistinguishable?
So let's meet the protagonist of this story to get us grounded. We have a 56-year-old gentleman. He's a farmer.
And that job title is actually the first major clinical clue in the file.
Right. It tells us he's outside day in, day out. He's not in an office. He's on a tractor.
High sunlight exposure. We see this constantly in the literature. It's an occupational hazard. He's been soaking up UV radiation for decades, probably without much protection.
So he comes in with a swelling on the right side of his nose. Says it's been there for 3 years.
3 years.
Started as a small bump, grew slowly. And the notes mention something that I think is a really important red flag. It ulcerated. He took some antibiotics. It healed up, and then it broke down again.
That is the classic wolf in sheep's clothing behavior of skin cancer.
It fools you.
It fools you. You think, oh, it's just a stubborn pimple or sore. It heals over, scabs, then breaks down again. That cycle is a hallmark of malignancy. It's your body trying to fight something that just won't go away.
Upon examination, the doctors describe it as a pigmented proliferative lesion, about 1 by 1.5 centimeters. It's sitting right on the
Wing of the nostril.
wing of the nostril and creeping up onto the bridge or the dorsum.
So they biopsy it, and the verdict comes back. Basal cell carcinoma, BCC.
Okay, let's unpack BCC. In the grand scheme of the big C, how worried should our farmer be?
Well, in the hierarchy of cancers, this is the one you'd want to have if you had to choose.
Right.
It's the most common form of skin cancer. And the good news is it very rarely spreads to other organs. It's not likely to kill you via metastasis to, say, the lungs or the brain.
But I feel a butt coming.
But it's locally destructive. Think of it like a termite infestation in the wall of your house. It's slow, but it is relentless.
It just keeps eating.
If you ignore it, it doesn't stop. It eats through skin, then cartilage, and eventually it eats through bone. We've seen cases where it erodes right into the nasal cavity.
So the mission is clear, get the termites out. But this is where the source material shifts from a medical diagnosis to a straight up engineering challenge. Because once you cut this out, you're leaving a crater in the middle of a man's face.
Exactly. And you can't just stitch the edges together. If you pull the skin of the nose tight to close a hole that big, you distort everything. You create a monster. So we're looking at a reconstruction involving flaps.
Okay, before we start moving skin around, let's talk about the demolition. The plan is a wide local excision. The surgeon plans a 0.5 centimeter margin around the visible tumor.
Which sounds tiny.
It does. Half a centimeter. What's that?
But on the nose. That's massive. That's valuable real estate.
Yeah.
But you have to do it because cancer cells have these microscopic roots that extend beyond what you can see.
There's a specific safety net mentioned in the notes called frozen sections. This sounded incredibly high pressure to me.
It is high pressure. It's real-time pathology.
So normally you send a biopsy to a lab, you go home, you wait a week.
Right. But here, the patient is on the table under anesthesia. The surgeon cuts out the tumor. Then everyone just stops.
Surgery pauses.
Pauses. They run that tissue down the hall to the lab, freeze it instantly, slice it paper thin, and look at it under a microscope right then and there.
While the patient is still asleep.
Yep. The surgeon is literally waiting for a phone call in the OR. If the pathologist sees cancer at the edge, they call down and say positive margin at 3 o'clock.
So they go back in.
The surgeon goes back and cuts more. They repeat this until the margins are clear. You do not start rebuilding until you have the absolute green light.
Because the worst case scenario is building a beautiful new nose on top of leftover cancer cells.
A total disaster. You'd hide the recurrence under the new skin until it was way too late.
Now, the notes threw in a what-if scenario. If this hadn't been basal cell, but say squamous cell carcinoma, SCC.
Oh, entirely different ballgame. SCC is more aggressive, it can travel along nerves, it can spread to lymph nodes.
So the whole plan would change.
Completely. They might have taken wider margins, they'd have been on the phone with an oncologist immediately to plan for potential radiation. It just changes all the rules.
Fortunately for our farmer, it's BCC. The margins are clear. But now, the surgeon is staring at the aftermath. The notes call it a defect, which is a very sterile word for what's basically a hole.
It's a full thickness defect. That's the key phrase. That means the skin is gone, the structural cartilage is gone, and the mucosal lining inside is gone. It's a window. You can look right inside his nose.
So this is the blank canvas. And the surgeon has to borrow tissue from somewhere. This concept of borrowing from Peter to pay Paul really defines plastic surgery, doesn't it?
It's the essence of it. You need spare parts, and you have to steal them from yourself.
The notes discuss 2 main contenders, the nasolabial flap and the paramedian forehead flap.
The nasolabial flap comes from that fold between your nose and your mouth, the smile line. Great for smaller repairs. Yeah. But our farmer has a big defect. It involves the structure of the nostril.
Right.
So the experts lean towards the heavy artillery, the paramedian forehead flap.
Okay, hold on. To the uninitiated listener, this sounds drastic. You're gonna slice a strip of skin off his forehead and stick it on his nose.
It sounds medieval, doesn't it? Like something from a horror movie. But it is the workhorse of nasal reconstruction for one very specific reason: the blood supply.
The supratrochlear vessel.
Correct. This is where we get into plumbing. You can't just cut a patch of skin off the forehead and slap it on the nose like a sticker. It'll die. It turns black and falls off.
It needs oxygen.
It needs oxygen. It needs nutrients. So there's this robust artery, the supratrochlear artery, that runs vertically from your eyebrow up into your forehead. The surgeon maps this out with a Doppler or just, deep anatomical knowledge. They cut a long vertical strip of forehead skin, but, and this is the crucial part, they leave it attached right over the eyebrow where that artery enters.
So it's like a tether.
Exactly. It's a pedicle, a bridge. The strip of skin is lifted up, but it's still pulsating with blood from that artery at the base. They rotate it 180 degrees and lay the end of it over the nose.
So for a while, this poor guy has a trunk of skin connecting his forehead to his nose.
He does. It hangs right over the eye. It's not subtle. You can't wear glasses easily, but it keeps the tissue alive while it heals into its new home.
Before we get to the logistics of that, I want to talk about a design concept in the notes that blew my mind. the Manicus concept.
Yes, the principle of subunits. This separates the amateurs from the masters.
The rule basically says, if you've lost more than 50% of a specific part of the nose, like the nostril wing, you don't just patch the hole, you actually cut out the rest of that unit
The healthy skin.
and replace the whole thing.
It sounds completely counterintuitive. Why make the hole bigger? Why remove healthy tissue?
Exactly. If I'm the patient, I'm saying, hey, save as much as you can.
But the human eye is a pattern recognition machine. We are very good at spotting interruptions. If you put a circular patch in the middle of a nostril, the eye sees the circle. It sees the scar. It looks like a tire patch.
Okay, I see.
But the nose is divided into these aesthetic subunits. The tip, the bridge, the sidewalls. These units are separated by natural shadows and creases. If you replace the entire subunit, the scars fall into those boundary lines.
You're hiding the seams and the shadows.
Precisely. You are fooling the brain. So when people look at the result, they just see a nose, not a jigsaw puzzle. It's optical illusion as much as it is surgery.
That is incredible. So we've got the skin coverage sorted, but you mentioned earlier, a nose isn't just skin, it's a sandwich.
Cover, support, and lining. If you forget any layer of that sandwich, the reconstruction fails. We have the cover, that's the forehead skin. Now we need the lining.
The inside of the nose.
Right. If you leave the raw underside of that forehead flap exposed inside the nose, it'll scar down and contract. It'll pull the nose shut like a drawstring bag.
So you need that smooth mucosal lining?
You do. And the sources list some MacGyver-level tricks for this. One of them is just folding the forehead flap.
You just fold it over.
It's elegant. If your forehead strip is long enough, you just fold the end of it under itself. So the outer surface is skin and the inner surface is also skin.
Like hemming a pair of pants.
A very bloody hem, but yes, that provides a nice durable lining. There are other options too, like septal flaps.
From the wall in the middle of the nose.
Yeah, you can swing tissue over from there.
Yeah.
Or delamination.
Which sounds delicate.
That's for the steady hands. You take the forehead flap and carefully slice it through its thickness, splitting it into two leaves like opening a book.
Wow. Okay, so that leads us to the middle of the sandwich. The support. The cartilage. Why can't we just have a soft nose?
Physics. The Bernoulli principle. When you breathe in, the air pressure inside your nose drops. If the nostril wall is floppy, the suction will collapse it shut.
It plugs itself.
It's called valve collapse. You try to take a breath and your nose plugs itself. So you need a stiffener, like a temple.
And where do you get that?
The best place is the ear. The conchal bowl of the ear has a natural curvature that mimics the curve of a nostril perfectly.
Now, there was a bit of a debate in the notes about when to put this cartilage in.
Right, the timing controversy. Do you put the graft in immediately in the first surgery, or do you wait?
Why would you wait? It seems inefficient.
Metabolic demand. Think about it. You have this forehead flap that's just been cut off from 90% of its blood supply. It is stressed.
It's just trying to survive.
It's struggling. If you shove a piece of cartilage under it, that's just one more barrier to oxygen. It separates the skin from the bed it's trying to heal onto. And our farmer is diabetic. Diabetes affects microcirculation. His small blood vessels are already compromised. So often, surgeons will wait. Let the flap settle, get robust, and then slip the cartilage in later.
This brings us perfectly to the idea of form versus function, because we're spending so much time talking about how it looks, but the source makes a striking comparison to a ring finger avulsion.
Yeah, this is a classic teaching point. If you lose a ring finger, you can build something that looks like a finger. But if it has no sensation, if it doesn't bend, if it gets in the way, is it a finger? Or is it a mannequin part?
And the nose is the same. It's not just an ornament for the face.
Not at all. It's a complex HVAC system for your lungs. Filtration, humidification, warming. If you breathe cold, dry, dirty air directly into your lungs, you are prone to infection.
Speaking of filtration, there was a detail in the source about the forehead flap that I found. Well, equal parts fascinating and slightly gross.
I know exactly what you're going to say, the hair.
The hair. Forehead skin has hair follicles.
It does. Even if you don't have a visibly hairy forehead, the follicles are there. And when you move that skin to the nose to line it, those follicles don't realize they've moved. They keep growing hair.
So you have forehead hair growing inside your new nose.
You do. And while that sounds odd, functionally, it actually mimics the nasal hairs that are supposed to be there. It helps filter dust.
That is a lucky evolutionary accident.
It is. But there is a downside. Forehead skin is thick. If you don't manage it, the patient ends up with a very bulky, thick nostril that looks like a blob. So often, a later surgery is needed just to thin the flap.
It really sounds like this is a marathon, not a sprint.
It absolutely is.
So let's talk logistics. We've got this farmer. He wakes up. He has a tube of skin running from his eyebrow to his nose. What happens to the hole in his forehead?
The donor site. Ideally, you just stitch it shut.
But you have to be careful not to give him an instant, unintentional facelift.
Or a permanent scowl. If you pull too tight horizontally, you drag the eyebrows together. If you pull vertically, you hike the eyebrow up. You don't want the patient looking perpetually surprised.
And the timeline here, he's living with this thing for how long?
For 3 weeks.
Why, 3 weeks?
3 weeks is the biological magic number. That's how long it takes for the new tissue on the nose to sprout its own blood vessels and hook up with the face's vascular system. It's called neovascularization.
So for 21 days, the nose is on life support from the forehead.
Correct. And at the 3-week mark, they might do a clamping trial.
What's that?
You clamp the bridge shut with a rubber band. If the nose stays pink, it's independent. If it turns blue, you unclamp it and wait a bit longer.
And once it stays pink?
You perform the flap division, you cut the bridge, you discard the excess, and you sculpt the final nose.
There was one final complication mentioned for a diabetic patient, the delay phenomenon.
This is fascinating physiology. If a surgeon is really worried about blood supply, say the patient is a heavy smoker or has uncontrolled diabetes, they might do a delay procedure before the main surgery.
How does that work?
They cut the outline of the flap on the forehead, severing blood supply from the sides, but they leave the flap right there. They just stitch it back down.
Wait, they cut it and then just leave it. Why?
To train the blood vessels. By cutting off the side roads, you force the body to pump all the blood through that one remaining highway, the supratrochlear artery.
It's like forcing water through a single pipe to widen it.
Exactly. It induces the vessel to dilate and align. It supercharges the blood supply. So a week later, when you actually move the flap, that artery is pumped up and ready.
That's incredibly clever. It's like vascular boot camp.
It really is. In this farmer's case, they didn't need it, but it's a powerful tool to have.
So, to synthesize all this, we started with a farmer and a nagging spot on his nose, a spot that turned out to be a termite infestation of cancer. And to fix it, we've gone through frozen sections, architectural planning, borrowing skin from his forehead, and leveraging the body's own vascular highways.
It highlights that reconstructive surgery is not about vanity. It's about identity.
That's a big point.
Think about it. We interact with the world face first. If you have a gaping hole in your face or a collapsed nose, it affects everything. How you breathe, how you sleep, how people look at you.
The notes touched on this humanity aspect.
Restoring the nose is about restoring the patient's ability to walk into a room without being defined by a deformity. It's giving him his face back.
Letting him be just a farmer again.
Not the guy with the hole in his nose, exactly.
It's amazing how much thought, how much geometry and physics goes into something as small as the curve of a nostril.
Every millimeter matters.
So what does this leave us with? For me, the standout is just the adaptability of the human body. The fact that forehead skin can learn to be a nose lining.
And that's the provocative thought I'd leave you with. We tend to think of our anatomy as static. This is an arm, that is a leg. But at a cellular level, we are incredibly modular. The fact that surgeons can map these hidden rivers of blood supply allows them to essentially remix the human body to heal itself. We're more interchangeable than we think.
It's like the body has a built-in repair kit, you just need the instruction manual.
And a very steady hand.
Well, I will certainly never look at a forehead wrinkle the same way again. It's just a potential nose waiting to happen.
Hopefully one you'll never need.
Exactly. Wear your sunscreen, folks. Thanks for listening to this deep dive into the engineering of the human face. We'll catch you on the next one.